Cool. All right, guys. So, cardiology. This is really the meat and potatoes of being a paramedic. Kind of really the differentiating line between BLS and ALS. We get to do some other cool stuff too, but really having a good understanding of cardiology and what you're reading on an EKG is essential. So, obviously, we're kind of familiar with this, but heart disease is the leading cause of death of both men and women in the United States. Men, it starts a little bit earlier, in like the early 40s. Women, it's postmenopausal. The risk factors of dying from heart disease, that protective estrogen starts to drop after menopause, and you become highly likely to die from a heart attack, just as the same proportions as men in that postmenopausal state. About 90% of people who do experience out of hospital cardiac arrests will die. A lot of the times it's due to the fact that people don't recognize that the cardiac arrest has happened. And secondary is that we do not have widespread CPR training like they do in other countries. Some of the risk factors that we do see that can cause heart disease, of obviously the male sex. Sorry, y'all, that Y chromosome is not doing you any favors. Strong family history, ethnicity. Blacks and Hispanic people are at higher risk of developing heart disease for a number of different reasons, including social inequities. And advanced age. As you get older, you are just kind of, your protective measures are not as strong. Also, if you have any sort of issue where you have high levels of inflammation in the body, also puts you at a high risk of developing heart disease. So anyone who has potentially like an autoimmune disease or stuff like that, that could also put you at a high risk for heart disease. Some of the controllable factors that are associated with heart disease, obviously smoking is a huge one. Diabetes and high blood pressure are also contributing factors, often because they create an inflammatory state in the body. High cholesterol in the presence of inflammatory issues is extremely dangerous, because there are plenty of people who have extremely high cholesterol but have no inflammation that do not develop heart disease. So it's a 1-2 kind of punch. High cholesterol paired with diabetes and hypertension is often extremely dangerous for cardiac health. Obesity as well. And there's different types of obesity. I mean, like, you look at sumo wrestlers and they're really large dudes, but the way that they exercise and the way that they eat does not create the same sedentary lifestyle inflammatory state that you would see like here in America. A lot of the foods that we eat are cooked in or fried and cooked in oils that create inflammatory responses. Fast food in general, the reason it's really not great for you is just the way it's prepared. High salt content, unhealthy fats, those are really what's causing a lot of the cardiac concerns that we see in the United States. Quick review of the heart, because we do like to review this and we do like to test you on this over and over and over. And that also very commonly will ask you to follow a drop of blood through the heart and body. But your heart does consist of 2 atriums on top. They are low pressure areas. And then you have the 2 ventricles underneath. They are a little more muscular. The left ventricle, which is the workhorse of the heart, really is much more muscular than the right ventricle. So any damage that happens to the right ventricle, you will notice a significant impact, as compared to where the left ventricle might have a little more muscle mass to kind of compensate. The right side is associated with the deoxygenated blood, right? This is goes from the body, returns from the body and goes to the lungs in order to become oxygenated, right? So it's a low pressure circuit, as opposed to the left side, which is a high pressure circuit, which it pumps blood all the way to your toes and your brain and everywhere in between. You have your atrioventricular valves, which are the valves between your atrium and your ventricles, the tricuspid and the mitral. Okay, the tricuspid has is on the right side, and the mitral, which has an L in it, is on the left. And then you have your semilunar valves, which are actually kind of not positioned inside the heart. They're actually positioned inside arteries. So you have your pulmonary valve, which is positioned inside the pulmonary artery, and you have the aortic valve, which is conveniently positioned inside of the aorta. Those are things that you definitely want to make sure that you are very familiar with. They will be questions that pop up on exams. The human heart does have 3 different layers of the heart. Again, they like to kind of test you on where the layers are. The heart is surrounded by a very tough fibrous layer called the pericardium. It keeps a little bit of fluid, it's about 10 cc's of fluid between the outside of the heart into this little cavity here, the pericardial cavity. There's about 10 cc's of fluid that reduces friction. So as the heart beats, it doesn't get hot, right? There's no like mild fire response that goes on as the heart does beat. Your myocardium, myo being muscle, okay? So this is the extremely the hard-working muscular part of the heart. And then you have the endocardium, which is this like very thin epithelial layer inside the heart. Endocardium or carditis often is seen as inflammation in IV drug users. Okay, it is very painful. It also ends up in what they call like a vegetation. So bacteria will come, and the vegetation will often kind of live on the heart valves and destroy the heart valves. It's just like a bacterial colony, and it is exactly kind of how you think when I say the word vegetation. It's just kind of this funky, amorphous blob of a bacterial colony. So when you think of the circulation in the heart, the myocardium, right, the coronary arteries are supplying the myocardium with blood. So if there's any sort of blockage, this is the part of the heart that gets damaged in a heart attack. This is also super important. Your cardiac blood supply, okay? You receive blood into the coronary arteries when the heart is undergoing diastole. So, one of the flaps of the aortic valve, when the aortic valve is open, which means that the ventricles are contracting, the aortic valve covers the opening to the coronary arteries. Okay, so when the ventricles are relaxed and the aortic valve is closed, the blood kind of flows backwards and goes into the heart. On one of my rotations, we had the cath lab when I was in medic school, and I asked one of the electrophysiology cardiologists, if the coronary arteries ever experience the pressure of systole? And he looked at me and was like, shit, I don't know. And he spent probably the next 2 hours trying to find the answer to it, which he never actually got a satisfactory answer. So if you think about it, these coronary arteries are kind of embedded in the myocardium. They only receive blood when the heart is relaxed. So if you have a blood pressure of 60/40, you're only receiving 40 millimeters of mercury worth of blood pressure into those coronary arteries. There was the thought that as the heart does contract, that the coronary arteries also are kind of contracted, which helps move blood along, but didn't get a confirmation on that one way or the other. So most importantly is just to remember that when the heart receives blood, it is also relaxed in diastole. So as the blood moves into the heart, into the coronary arteries, it splits into 3 main coronary arteries. The right coronary artery, which you see over here, which kind of comes down and supplies the blood to the SA node up here, and kind of the whole right side of the heart wraps around, and it also hits part of the inferior wall of the heart. That's important. Exactly. which is why if you have a patient who is in VTAC with a pulse, they can only sustain it for so long before they do go into cardiac arrest. Good question. All right. So then as you have the blood comes down the left anterior descending, it splits up here into the left circumflex, or just the circumflex. The circumflex gets the lateral wall of the heart, and the left anterior descending gets the whole, like the septum and the majority of the left ventricle, okay? The left anterior descending artery is most commonly associated with the widowmaker, okay? So if there is an occlusion up here in the left anterior descending, it's taking out a significant portion of the heart muscle, which is why it's so dramatic in its death rate. Another way that you can kind of see the way that the heart receives different levels of blood and the areas in which it supplies. So left circumflex gets the left atrium, parts of the left ventricle. Left anterior gets the septum, left ventricle, part of the right ventricle. The left marginal, we don't really need to know specifically, but is also part of the left ventricle. The right coronary, which you kind of group the right marginal into, gets the right atrium, right ventricle, and part of the inferior wall. So a really cool thing about the heart is that if there is some level of disease in a vessel, the body will create what's called collateral circulation, or, anastomosis. I have to actually look at that in order to say it appropriately. Anastomosis are these collateral blood vessels that work their way around a blocked artery. So if you have someone who has coronary artery disease, they might not have a heart attack right away, because if it's a gradual process, the body will actually create these little blood vessels to continue to supply the muscle around the area that's blocked, okay? It's like a little bypass, like you're driving on the highway and there happens to be, construction, and they bring you out to the service road and back around. Same kind of concept. So this in particular is why older people will survive cardiac arrest more likely than a younger person, okay? So all of that extra the blood vessels in the heart allow for better circulation in the event of a ischemic event with a clot or something to that effect. Any questions real quick? All right, cool. So, physiology.
70 units assigned to funeral detailing, shut down your intersections. We'll be leaving shortly.
So we talked about this a little bit already, right? The right side is low pressure and gives the pulmonary circulation its blood, whereas the left side is high pressure and is systemic circulation. So one of the reasons that AFib, right? We talk about AFib a lot and how it's not a normal heart rate. The normal reason that it's so devastating overall is because you lose what's called the atrial kick. So with passive circulation, about 70 to 80% of the blood will just naturally flow from the atria to the ventricles. However, when you have a coordinated contraction of the atria, it adds another 20 to 30% of blood into the ventricles. When you're trying to produce blood pressure, or you need to stretch the heart in order to have a really good cardiac output, right? It's called the Frank-Starling effect. It's sort of like a rubber band. The further you stretch it, the further it'll fly when you let go. So if you don't have that added 20 to 30% of blood stretching the ventricles, the blood's not going to go as far. Does that make sense? So you lose a lot of efficiency when you have an uncoordinated atrial contraction, which you usually see in AFib. The other problem is now that 20 to 30% of blood is just kind of chilling, right? It doesn't passively move, which means that over time it starts to coagulate. Okay, so if you have a little bit of some coagulated blood just hanging out in your atria, and all of a sudden it has one really solid coordinated contraction, you're now sending blood clots into main circulation, which is why most patients who are on who have AFib are on some level of blood thinner, right? It's most of the time they use Coumadin, but there's a number of other medications that they're putting into effect, like Xarelto, to kind of reduce the risk of stroke, because and PE, because once you start floating those blood clots around, it's anybody's game to see where they end up, right? So this is why having a good, solid heartbeat is always nice to have. This is also why when you're treating a patient who is in AFib, you want to know if it's a new onset AFib or not. Because if you do happen to fix their AFib, you could cause them to have a stroke if they're not being thinned. Their blood isn't being thinned previous to the fixing of their rhythm. So when we talk about the heart, we talk about something called preload and afterload. Preload is the amount of blood coming into the heart, right? So we talk about atrial kick, right? That we talk is preload, right? The amount of blood coming back from systemic circulation that can stretch the heart muscle in order to create output through the Frank-Starling effect. Afterload is the amount of pressure that the left ventricle needs to pump against, right? So, well, both ventricles, right and left. So if you have a heart that is weakened, right? Maybe you had an MI or heart failure, right? And it's not as efficient as it used to be, and it can't pump against the systemic pressure, you're going to have what we call cardiogenic shock, right? It's a pump problem. So if you see this very often in patients who have like acute pulmonary edema, right? So if their blood pressure starts to rise, the heart can't pump against that or effectively push blood against the pressure. So it builds up back into the lungs. So think about sort of like when you have a garden hose, right? Garden hose is good. It's running, no problem. And then you put your thumb over it, it starts to spray everywhere, right? You've increased the pressure, which means that you've kind of changed the way in which the water flows from the hose. Sort of like the same thing, except the pressure is the resultant of every single blood vessel in the body, right? So if you have, this is why Levophed works, right? You're increasing the afterload by reducing the size of the capillary beds, by reducing this, by constricting all of the blood vessels in the body so that the heart pushes harder against it and it raises the blood pressure. We talked about preload already. We talked about afterload. Contractility, right, is how well, myocardial contractility is how well the heart muscle can pump, right? And we talked about this with electrolytes a little bit, right? So you rely on calcium in order to improve the contractility of the heart muscle. If you give a patient a pressor, these also alter how well the myocardium can contract. Stroke volume is also an important term to know, right? This is how much blood is ejected from the heart every single time the ventricles contract. And it's going to be different for each person, right? So this is why elite athletes have such a low resting heart rate, right? Because they have a very efficient left ventricle. So they can pump out more blood every contraction than other people can because they've trained that muscle. So this is why when you start dealing with people and, they might have a good blood pressure and their heart rate's really low, this is why part of your patient assessment should be, okay, do you work out, right? Is this normal for you? Or, this is also why when you have somebody with a really high heart rate, the stroke volume is going to drop because it doesn't have enough time to fill, okay? And that means that when it can't fill, the myocardium isn't stretched and you aren't going to be able to output as much as you would at a normal rate. So we talked about the Frank-Starling law a little bit. This is a little more of a definitive definition that your myocardial fibers will contract more forcibly when they are stretched, but only to a certain point, right? It's sort of like when you're stretching a balloon. You can blow up a balloon and it will stretch and then it will deflate and push against the walls will push against the air, forcing that air back out. However, when you reach a certain point, that balloon can burst, right? Your myocardium isn't necessarily going to burst, but it's going to not have the same appropriate force as you push against systemic resistance. This is often really what we see as the cause of an issue in congestive heart failure, right? That ventricle has gotten so stretched out that it can no longer effectively pump. And it's getting stretched out because of high blood pressure forcefully stretching, or unusually uncontrolled high blood pressure, forcing that left ventricle beyond its stretching limits. This is an important concept to understand. Okay, this formula is an important formula to kind of understand. Cardiac output is equal to stroke volume times heart rate. Okay, so for example, if we say that the average adult has a stroke volume of 500 milliliters and they have a heart rate, let me write this down so I can do the math properly, and they have a heart rate of 60, your cardiac output is going to be 500 times 60, which is 3,000 milliliters a minute. Okay, does that make sense? So every heartbeat, which you have 60 in a minute, is pumping out 500 milliliters. Okay, that makes that their cardiac output is going to be 3,000 milliliters a minute. So the human heart is hooked up to the sympathetic nervous system, okay? The nerves come out right from around the thoracic spine, and the norepinephrine is the main neurotransmitter. This is what helps stimulate heart rate and contractility. Norepinephrine also is in control of dilating and constricting the coronary arteries, as is the sympathetic nervous system. However, you would not survive very long or very well if you only had the sympathetic nervous system constantly telling your heart to beat, right? Is that going to just overdrive your system and be like in that fight or flight response area all of the time? So your body put in this governor, which is the parasympathetic nervous system, right? So your vagus nerve acts as like a governor for your heart rate, which is why the SA node keeps you at about 60 to 100, because the parasympathetic nerve, or the vagus nerve in particular, comes in as like, chill, brah. We're going to keep this nice and cool because we don't want to overheat. We don't want to work too hard. We're chilling, okay? So that's what keeps the rate out of, really high ranges. You can have too much parasympathetic stimulation, right? So sometimes this is why we give a patient, for example, atropine. Okay, atropine helps remove the parasympathetic control. So if you have someone who's extremely bradycardic, there's a good possibility that the vagus nerve is being overstimulated. You give them atropine and it reduces that stimulation of the parasympathetic nerve. Now, on the other side, when we give adenosine, it improves the parasympathetic tone on the heart. So it takes a really high, fast heart rate and tones it back down, right? It stimulates that vagus nerve to be like, we need to reset, guys. This is too fast. So you kind of think of those medications and what they do. You can kind of understand how the nervous system affects the heart. There is a certain level of hormonal regulation when it comes to the heart. It commonly occurs in the adrenal medulla. So I read a really interesting case study of a woman who had out of control blood pressure, high blood pressure. Medication that they tried, every single medication didn't work, and they couldn't figure out why her blood pressure was so high. They did a scan of her kidneys, and they found out that her kidneys, there was blockages in the renal arteries. So the kidneys are really important when it comes to controlling your blood pressure because they require a blood pressure of 50 or greater in order to do what they're supposed to do. This is why when you have a critical patient, they put a Foley in order to measure urine output, is because if the kidneys are healthy, the blood pressure's in a good spot and vice versa. So if you have a patient who's not making any urine, there's a blood pressure problem. So the adrenal medulla, what it does is it controls the blood pressure by transmitting by releasing epinephrine and norepinephrine. So they both work on the sympathetic nervous system side, but in slightly different ways, right? So the norepinephrine will constrict the blood vessels in the periphery, while stimulating the cardiac muscle to pump faster and harder, while the epinephrine dilates the blood vessels in the skeletal muscle and the heart, while constricting blood vessels in the skin, in the GI system, in the kidneys, right? So it's shunting everything away from your external area and bringing it into the center, because your body wants to save your heart and your brain before anything else. So working together, this creates that shunting effect. So you'll see that in a lot of patients who are still compensating in shock, okay? Like this is the action that's occurring. Any questions before we move on to electrophysiology? Okie dokie. So the heart is a unique muscle in so much as it can create its own electric, and this is called automaticity. This electricity is generated through electrolytes, okay? So we talked a little bit about electrolytes earlier in the previous module. The three main players here are calcium, potassium, and sodium. Okay, magnesium is important, but we don't talk about it too much because it's there, but it's not as vital as the other three. Okay, so if you think about your electrolytes, if you draw a circle and then you put a K inside of it, like a big old OK, most of your intracellular electrolytes are potassium. And everything outside is sodium for the most part, okay? This is how it creates a gradient, an electrical gradient between the two, okay? Because potassium is a 2+ electrolyte, right? So it has 2 positive, and sodium has a 1 positive. So if you have relatively equivalent amounts of the 2 electrolytes, it will create, as I said, this electrical gradient. Mm-hmm. Yes. Yep. So here's your action potential. Thank you for the lead-in. So the gradient is maintained by what's called the sodium-potassium exchange pump. This pump requires ATP to work, okay, because it is moving electrolytes against the normal gradient, right? So we talked about diffusion. The body wants to have, everything to be equal. Inside the heart, though, the heart is sitting at a -70 to -90 millivolt status. That's the word I'm looking for. Status at resting potential, right? So it is a more negative charge inside the heart than outside the heart. When your body goes through the complex motions of saying, hey, we need a heartbeat, these pumps are triggered. Then they're activated using energy, right? So if you have no energy in your body, you cannot activate these pumps, and then you die. So basically, your body gets a signal that, well, okay, we're going to now move this sodium into the heart, and it makes it more positive inside the cell than outside the cell, okay? And it's called depolarization. This is when the electric starts to move from the SA node down along the electrical system of the heart through the atrial pathways to the AV node, where it takes a little break, and then down this septum, the bundle of His, to the Purkinje fibers, okay? The Purkinje fibers are possibly part of my favorite part of anatomy, just because it's fun to say Purkinje. So, after the heart is depolarized, the cell is depolarized, and the action is no longer potential, but is actually moving, it starts to rebalance your electrolytes, which is called repolarization. And we're going to talk about this a little more in depth when we get to the actual EKG, but there's a moment in time where these pumps cannot be reactivated, okay? And it's during that time where you cannot have another heartbeat, okay? But then it sort of The refractory period, perfectly described. So there's two parts of the refractory period. We're going to talk about that in a little bit, but if you hit the heart at a very specific time during the refractory period, you get what's called the R on T phenomenon. This is what was killing like little league players who were getting hit in the chest with baseballs, is they would hit them during the part of the refractory period and putting them into VFib. Okay, so just keep that in the back of your mind. We'll talk about it in a little bit. So we're here at repolarization, right? So it's a process where now these pumps are putting everybody back where they need to be, right? So the potassium goes back into the cell, the sodium is pumped out of the cell, and we're back at resting action potential. And this happens millions of times, trillions of times in your lifetime, okay? Every time your heart beats, this is the process that occurs. So if you take this picture right here, this one, right, it also becomes this little chart. We are not going to spend too much time on this chart because you would not need to know it after cardiology, okay? But you do need to understand the phases, okay? So the phases are important. So the first thing is right here, right? So we're at the action potential stage, right? Right here where the heart's happy at a negative 85 millivolts. It's hanging out here. Think about this as your isoelectric line, okay? Nothing is happening electrically. It's chilling, waiting to be stimulated, okay? And then all of a sudden you have phase 0, right? And it just an increase in millivolts, right? Above to a positive, a positive millivoltage, okay? And this is where you have this massive influx of sodium as well as some calcium into this inside of the cell, okay? And then this is depolarization. Up top, that's where the heart is depolarized, okay? And then as you go through the phase, this is when like things start to be put back together, right? Your refractory period, the heart has been depolarized. It's starting the process of repolarization. We are actively pumping potassium back into the cell and sodium out of the cell till we get back to our action potential. Okay. Yes. Yes. Yes, and there are fast calcium pumps and slow calcium pumps because after depolarization, the fast calcium pumps drag as much calcium inside the cell in order to create a strong contraction. And then there's a slow calcium channel kind of puts them back outside a little slower because it wants to hold on to it in order to maintain that contraction, the ability to contract. And that's also why you have that squiggle. It's the difference between your fast calcium and your slow calcium pumps. So anything that changes the cell's permeability is going to affect how this action potential takes place, right? So for example, talking about calcium, if you have calcium channel blockers, right, it's going to prevent a large amount of this calcium from making it inside the cell. And if it can't get inside the cell, then the cell is not going to be able to contract as powerfully as it would if it had all the calcium it needed. Okay, and this is how a calcium channel blocker works in reducing heart or blood pressure, right? The heart can't pump as hard, which means it's taking a lot of the oomph out of that ventricular contraction, and thereby reducing stroke volume and therefore reducing your cardiac output. Another view of this, this adds to your chloride, talks about your chloride a little bit, right? Really the ones you want to focus on the most is your potassium being inside the cell, the sodium rushing in, the calcium also coming in these slow channels, and the fast channels, and then being pumped out in the slow channels, okay? And this is just talking about this again. So, right, so you have here at phase 0, at this corner right here, this is when the fast sodium channels open and sodium goes flying into the cell. And as sodium starts going into the cell, potassium starts getting pushed out of the cell, okay? Now, this doesn't seem like a huge millivoltage, right? Plus 52 millivolts, right? It's a kind of small, right? If you had a lot more voltage in your heart, you'd probably feel every single time your heart was mildly electrocuted because of this shift. But this is it's in relation to what the rest of the outside of the cell is, right? So that's why this is a significant change in electricity. It also needs to go above the threshold in order to lead to muscular contraction, right? So there's an electrical threshold that, if you don't generate plus 52 millivolts, or give or take, right? If you only enough sodium goes in to get you to 0 millivolts, you're not going to have a muscular contraction, okay? So this is why electrolyte imbalances are also significant, and they can change the way the EKG looks. Phase 1, right, the fast sodium chain closes, so the potassium starts to leak out, which means that the cell becomes a little less positive. And then phase 2, you have the potassium continues to go out and the calcium starts to go in slowly in order to complete muscular contraction. And then phase 3 is we're rapidly returning back to a resting action potential. Sodium channels close. There's more negative than positive inside the cells because everybody's back to where they need to be, right? So you have your sodium is outside the cell, your potassium is inside the cell, and your calcium is going back outside. And then your phase 4, you're back at your resting action potential, and this will all start again once the sodium potassium exchange pump is activated. So we talked about this a little bit already, right? But you have the two refractory periods, okay? And it kind of lines up with the your action potential chart, but more importantly, it lines up with your EKG. So the refractory, so we said here, right, this is the depolarization. The only depolarization that you will see on an EKG is like the significant. You'll see the atrias are the P wave, and the depolarization of the ventricles is your QRS complex. From the end of the QRS complex, which is called the J point, to the end of the T wave, which is your repolarization, you will very rarely see atrial repolarization on an EKG because it gets eaten up by the QRS. So from the J point to the end of the T wave is your refractory period, okay? And then that's split into absolute refractory, which is from the J point to the top of the T wave, and your relative refractory, okay? So that's the top of the T wave to the end of the T wave. The relative refractory period is where little baseball kids go into VFib, because if you hit the heart with enough force in this little portion right here, you will put them into VFib, okay? It takes a lot more energy, but it's still possible that one can do it, okay? So, yep, that's about that there. The SA node is the main pacemaker of your heart. It usually maintains a pace from 60 to 100. If the SA node fails, the atrias will attempt to take over, or a cell within the atrias will attempt to take over. Again, it will usually be in the 60 to 100 range as a rate, but as you get further away from the SA node, the lower the rate of inherent discharge, or inherent electrical discharge that the heart experiences, okay? So the AV node, the inherent discharge rate is 40 to 60, and the ventricles, which is the bundle of His, or anywhere down along the Purkinje fibers, is 20 to 40. Okay, so this is why when you have somebody who maybe has had some sort of issue in the heart, they put a pacemaker in because they're trying to keep it here at this rate. These rates are often too slow, and because they're also lacking atrial kick. Okay, because the atrias are not necessarily experiencing a coordinated depolarization that you experience with the ventricles or with the normal conduction system. So here we go. Here is your first taste of what the EKG will look like. So you start here. Your ISO, we call this your isoelectric line, okay? Your heart is at its resting action potential. It is waiting for a stimulus, and the SA node is proud to provide you with that stimulus, okay? So as the SA node electrically discharges, it creates or depolarizes, it causes what we call the P wave, okay? P wave is this cute little tiny bump, camel bump, right before the QRS. So the P wave follows the electrical stimulation across both atrias and down to the AV node. Now, we all know that there is a slight pause at the AV node to give the ventricles adequate time to fill. That's this little purple splash right here back at the isoelectric line, okay? There's no electrical stimulation going on here, and it's a very brief moment, but it's an important moment. Then the AV node sends its electrical stimulation down the bundle of His to the Purkinje fibers, and this is what creates the QRS complex. So as you see here, see how the electric goes down the septum and then up the walls? It goes down the septum and then up the walls, okay? So your QRS is usually biphasic in so much as like it goes in both directions, whereas the P wave goes one way, right? Just going straight down. The QRS goes down and back up, which is why it gives you this shape. Now you have the depolarization of the entire heart, the ventricles on the bottom, right? You have this little momentary pause as they actually physically contract, and then depolarization happens. This is your T wave. Depolarization happens in the direction, backwards in the direction it came, okay? So it comes back down this way. And then your heart's back at its resting action potential. So we'll talk about that probably a little bit more in depth in a little bit, but I just want you guys to kind of remember, like, this is the pathway that it goes. The depolarization is your T wave is almost always the same direction as the QRS, because the QRS is a positive impulse headed toward a positive electrode, and the T wave is a negative impulse headed towards a negative electrode, which creates a positive deflection. Probably a lot to kind of take in there, but just write it down and then we'll revisit it later, and it'll probably make a little more sense. So there is a number of different, this is a little bit out of order in terms of what you're learning for EKGs, but this is also kind of important to know that you can have what's called ectopic foci. Okay, this is a beat that comes from somewhere other than the normal electrical cycle. Okay, so it could come from anywhere within the heart, and it's classified based on its origin. Okay, so if you have an atrial cell that is feeling a little frisky and decides to output some electrical impulse, it will be called a premature atrial contraction. Junctional contractions, usually at the AV node, is a premature junctional contraction, and anything from originating from the ventricles is considered a PVC or a premature ventricular contraction. We will go a little bit more in depth about those in a little bit. And here's another lovely little picture for you, right? So PVCs, you can kind of identify them on an EKG as like wide, bizarre looking, funky guy, okay? PACs are usually a little more difficult, and PJCs are usually a little more difficult to determine because they look a lot like the regular rhythm, except usually they're not in the right like spot. Okay, so PAC is coming a little sooner than the next beat would be anticipated, as is a PJC. PAC, if you kind of look closely, you see how this P wave looks like very clean, and this P wave looks a little different. That's how you would determine. The morphology of the P wave gives you that idea. And the PJC does not have a P wave because it's coming from the AV node. Because it's following the normal electrical pathway, however, it will be this like cute, tiny, tight complex that looks kind of like everybody else. For the most part, when you have these extra beats, it's often caused by an enhanced automaticity. So it could be an electrolyte issue. It could be a caffeine issue. So very common in younger people is that you can give yourself ectopic beats due to increased caffeine intake. But electrolyte imbalances are very commonly a cause. PVCs are most frequently caused by hypoxia. So if you have a patient and you're checking them out and their SpO2 is maybe on the lower side, and you put them on the monitor and you see all these PVCs, the easiest way to fix it is to give them oxygen therapy. Sometimes other catecholamines, right? So if you when you almost get in a car accident or something, you feel like your heart's going really fast, you might be having some PVCs or PACs or PJCs because of the excessive epinephrine from that fight or flight response. They don't really use digitalis as frequently as they once did, but patients who have taken too much of their medication can be seen to have a lot of ectopic issues as well. For the most part, when we see ectopic impulses, especially in AFib, it's caused by what we call re-entry. So the electric moves down this very strict kind of path, right? And as it moves down, it goes in all directions. It cancels each other out here, and it carries its way on down the line in order to do what it's supposed to do in both directions. However, if part of this loop is damaged, or there's a block or something going on here, it will get stopped here. It'll get stopped here, but will continue on this way, which allows for a secondary conduction. It's sort of like a loop, or like Groundhog's Day, right? So like if you think about the electric as Bill Murray, and he's constantly waking up, the same day. He's stuck in this loop right here, right? And he's constantly having the same thing over and over, right? It's the same impulse going on in the heart over and over until you break the cycle and return it to normal, the normal flow. If that kind of makes sense. Again, this can be caused by electrolyte imbalances, particularly potassium. Hyperkalemia can do this. Some medications can cause this. MI, right? Because if it's causing damage where this there's no blood flow to this part of the electrical system here, and it's suddenly a block, this can cause this. And here you go. Here's another picture kind of explaining how this works in the terms of reentry. This is often what happens in AFib, especially rapid AFib. You get these little reentry cycles, which can cause the heart to end up beating very, very fast. Questions? Okie dokie. So, basic concepts for EKG monitoring. When your heart depolarizes, as I showed you on that chart, it will generate a positive electrical current. So, depending on which lead you're looking in, depends on the deflection of the EKG. Okay, and we're going to talk about Einthoven's triangle in a moment. But the positive electricity moves essentially from your right shoulder to your left hip. Okay, think of that as the main vector of your heart. So you have positive electricity going from your right shoulder down to your left hip, and if their positive electrode is also located on your left hip, you will have a positive deflection on an EKG. Okay, if you have the positive electricity going towards a negative electrode, okay, say for example your left shoulder, okay, there's a negative electrode. If you have from right shoulder towards the left hip, it's going towards that negative electrode as it passes by, you will have a negative deflection. And then if you have negative electricity going towards a negative electrode, right? So if for example, you have electricity moving, negative electricity, right? So instead of it going upwards, it's repolarizing. This is the T wave we were talking about. It's going from your left hip to your right shoulder in the opposite direction of the flow. You will also have a positive deflection. Sort of remember back to when you were learning how to do working with negative numbers in middle school or whatever, how a negative times a negative is a positive. Same concept. Okay, a negative deflection or negative electricity towards a negative electrode is a positive electric change. As I promised, Einthoven's triangle. So if you put yourself in the same position, the leg lead is always a positive electrode. Okay, the right arm is considered negative and the left arm is considered positive. Okay, so in lead 1, which is when you're looking straight across the chest, right? You're essentially looking at the top part of the heart. Here's your right shoulder to your left hip. You have electricity moving from the right shoulder to the left hip, so it's positive towards a positive because it's in the same general direction, but it's looking this way. You will have what's kind of like a biphasic QRS, right? Because it's moving towards it and then away from it. Lead 2, which is our most commonly used monitoring lead, because it looks at right along the right side of the heart. You have positive electricity moving towards a positive hip, right? A positive foot. So you'll have an upright QRS, right? Very positive QRS. And then if you're looking at from the negative down the other side, right, down the left side of the heart, you still have positive moving towards a positive. You're still going to have an upright QRS complex in lead 3. What happened when we have monitors, which is kind of cool, is what they do is they use an algorithm to create what's called an augmented limb lead. This is your AVF, AVL, and AVR leads. So basically what it does is rather than looking from one to the other, it uses this whole angle as one lead. So you're looking actually from your chin down to your foot. So imagine if you look straight down, that's the image that you're seeing of the heart. Okay, AVF commonly in a normal looking EKG is a positive deflection. So now if you took a camera and you put it on your right hip and you looked up at the heart towards your left shoulder, this is the view that you're going to see, right? So you have electricity moving this way and down across. So again, it's going across this camera view, so it's going to have a biphasic up and away, right? Because it's moving towards and then away. And then if you use here, so you're looking from the left hip up towards the right shoulder, you're going to have positive. It's going to be positive going towards a negative lead, so it's going to be a negative deflection. Okay? We're not going to do that right now. Hold on. I wanted to give you guys a good EKG. It's probably a little later in the to show you what a normal EKG looks like, but I'll catch up with that in a little bit. So we're going to learn this real quick. You're going to draw this chart out, and then you're promptly going to forget it until you do probably your refresher. Okay? But you need to understand what axis deviation is, and kind of what it means. Just the implications of what an axis deviation means. So, a normal axis exists in this blue spot right here, okay, between negative 30 degrees and positive 90 degrees. Every time you print out a 12-lead EKG, it gives you numbers for the axis. So if you see a number between positive 90 and negative 30, you have the proper axis, okay? We address this on our own without the calculations. As when we look at lead 1, and lead AVF. So if the QRS in lead 1 and the QRS in lead AVF are both positively deflected, they're both upright, you have a normal axis, okay? If you look at lead 1 and it's going up, and then you look at AVF and it's going down, it is over here in a left axis deviation. So we're going to go through this a little more in depth in a moment, but usually left axis deviation can be attributed to things like pregnancy or obesity, where the heart is kind of moved up and to the left a little bit by usually like a gravid uterus, but it also can indicate that there's some damage to the right side of the heart because you now are changing where the vector of the electricity is moving. That's kind of a lot to take in, and I'll explain it a little bit better in a moment. So now if lead 1 is negative, right, negative deflection, and lead AVF is a positive deflection, it's a right axis deviation, okay? Again, we'll talk about what that means in a little bit. And then if you have both negative deflections in lead 1 and AVF, the first thing you should do is make sure that your leads are on properly, okay, that you did not switch your left and right sides, because otherwise you have what's called an extreme axis deviation. Very rarely seen. Often the most useful thing that you're going to kind of get from using the axis deviation is determining the difference between VTAC and an SVT with aberrancy. Aberrancy being that the electricity is not going down the normal pathways, so you have a wider QRS complex than you'd expect. So we'll talk about that more as well. But keep this chart in your notes, okay? We're going to kind of re-reference it in a little bit in the next lecture. So when you are applying your EKG leads, right, I think the right arm, left leg, right leg is pretty self-explanatory. We also have the precordial leads, which are the ones that look straight at the heart, okay? So where the Einthoven's triangle is looking across the heart, this is looking directly into the heart, okay? Like a mirror. Like if you cut open like a little mirror around each electrode that you place, it would look directly at the heart itself. The normal way that the electric moves around the heart is how you see down here, okay? V1 and V2 are primarily negative deflections. V3 and V4 are biphasic, right? They're a little bit on top and a little bit on bottom, where V5 and V6 are usually upright, okay? Because if you think about it, the electricity is moving directly towards them in this direction, so they're going to have that upright action. If you don't have this normal, what is called a normal R wave progression, there's often something wrong, okay? When you're placing your electrodes, it's V1 and V2. V1 is the only one that goes on the right side of the sternum. V2 goes on the left side of the sternum directly across, right at about the fourth intercostal space. The next lead that you place is V4, okay? V4 is mid-axillary line, just under the breast, okay? So if it's a female, you're obviously going to have to lift that up and put it down, but it's commonly at the fifth intercostal line. Then V3 goes in between V2 and V4, okay? And then V5 and V6 follow that intercostal space around, so they might actually go up a little bit, right? Because ribs are kind of curvy. V5 is at the anterior axillary line, right? So the very front of your armpit. And V6 is mid-axillary, okay? And that's the proper placement for your precordial leads. And here's another picture. So the unique part about the precordial leads is they look directly at what's right behind them, right? So if you look right here, it gives you an idea of what you're looking at, right? So again, nice picture of the heart right underneath the ribs. V1 and V2 are looking at the septum, okay? Because the heart doesn't sit in your body kind of how we see it in pictures. The primary part of your heart that's right underneath the sternum is the left ventricle, okay? So that the right ventricle is sort of more towards the back, and the left ventricle is towards the front, with the septum being like almost directly behind the sternum. So that's why V1 and V2 look directly at the sternum. V4 and V5 are looking at the anterior wall of the left ventricle, which is gets its blood from that left anterior descending. And then V5 and V6 look at the lateral wall of the ventricle, okay? So as it moves around, you're getting a full and complete view of the wall of most of the left ventricle. This chart will be super helpful for you when you start doing 12-lead interpretations. Not only does it tell you what parts of the heart each EKG lead is looking at, but it also tells you which artery supplies blood to that location. Okay, so starting with the precordial leads, because we just did it, right? V1 and V2 look at the septum, and they're supplied blood by the left anterior descending. V3 and V4 look at the anterior wall, again, left anterior descending. V5 and V6 look at the low lateral wall of the left ventricle, and this is supplied blood by the circumflex. That's what CX stands for, is the circumflex. Lead 1 and lead AVL also look at the high lateral wall and are supplied blood by the circumflex, whereas leads 2, 3, and AVF look at the inferior wall and receive blood from the right coronary artery. Now, you're going to hear this a lot in EKG interpretation, is that you need to find changes in contiguous leads. Contiguous leads mean things that are looking at parts of the heart that are right next to each other. So, V1 and V2 are considered contiguous. V2 and V3 are considered contiguous, right? Because it's just one electrode over. V3 and V4, V4 and V5, and then V5 and V6 are considered contiguous. Now, because this looks at the low part of the wall and this looks at the high part of the wall, these are also considered contiguous. Usually you'll see changes in like all 4 of these, okay, because it's the same artery. But it's a possibility that that clot got further down along the artery and is only doing damage to the lower part of the wall as opposed to the higher part of the wall. Leads 2, 3, and AVF, these are considered contiguous with each other, okay? It doesn't necessarily mean that they're next to each other on the EKG. It's what part of the heart it's looking at, okay? This seems to be a concept that trips up a lot of medic students, and even some medics that I actually know that have a hard time understanding that it's more about the wall of the heart that the lead is looking at as opposed to like physical location on the EKG. That's why these are considered contiguous. Another image, if this is more helpful for you in terms of remembering what arteries are affected. We don't talk about lead AVR all that much, mostly because it's not particularly used in pre-hospital care. And even a lot of cardiologists don't really give AVR a lot of attention, but AVR kind of primarily looks at the aorta. So if you have some sort of bizarre change in AVR, it's a strong possibility that there's an aortic dissection or something else kind of funky going on in the aorta itself as opposed to in the heart, but because they're so closely intertwined, it's still significant. So when we look at an EKG monitor, we primarily use lead 2 because it gives you a really good view of the atria, the P waves, which are there, kind of one and the same with the atrias. So if you are looking to monitor for AFib or something like that, this is where you're going to see it. V1 is also super useful because it's looking directly at the sternum and it picks up the P waves in the heart really good as well. There's another random little pro tip lead that you can also use. You take V1 and you put it right at the sternal, under the sternal notch. I think it's called the MCL something lead. Just some advanced EKG stuff, but it'll also give you a nice view of the P wave. EKG tracings can be impacted by a number of different things. For the most part, patient movement is going to be like the number one thing you'll deal with, okay? So, right, so patient can't sit still, they're seizing, they're shaking, right? You're going to get some funky looking tracing like over here. Sometimes you'll have cables that'll die on you, which is extremely frustrating. Depending which department you work for, you might have dried up conductive gel, right? So if you're working for somewhere a little slower and someone left an open bag of EKG electrodes, those dry out. If you don't put the electrodes in the correct spot, you can also have some issues. Diaphoresis is another common one. This right here, this middle EKG is the usually lighting interference, so fluorescent lights. I used to tell a story like the PAPD used to have their own ambulance at JFK, and they had some intense electric or fluorescent lights on their ambulance and would always give us this level of interference. We'd have to tell them to turn the whole ambulance off to get the lights to turn off so we can get a clean 12 lead, which is kind of wild. If you look at this kind of up and down motion, you will very commonly see this in very skinny patients as they breathe. Okay, this is just usually commonly caused by breathing, but a very narrow anterior posterior or AP chest diameter makes it a little more significant and noticeable than on like people who are got a little meat on their bones. Important things you need to know about EKG graph paper. 1, it's commonly pink. 2, it moves at 25 millimeters a second. Okay, so if you have 25 millimeters of paper, you have 1 second worth of heart rhythm that you're looking at. Okay, the EKG paper is broken down into boxes. Okay, there's large boxes and there's small boxes. 1 large box is 5 small boxes. And we're going to go do a little math right now, but it's super easy math, and I want you to think of nickels. So if you have a large box, okay, a large box is 0.2 seconds. A tiny box is 0.04 seconds. Okay, so when you're looking at a 12 lead, right? See how it's split up in the 4 sections? It is 12 seconds of EKG, okay? 12 seconds of heart viewing. The portions that's right here, this is all occurring at the same time, but at different views, okay? So when you're looking at it from a column, right, the up and down vertical portion, so this is lead 1, this is lead 2, this is lead 3, for example. This is all happening at the same time, just from different camera views. But what's happening here at lead 2 is not happening here at the same time at AVR. Okay, so this is, your time is moving forward here. It's the same time up and down here. And some people get a little stumped by that. So just wanted to clarify. Now, there is, I don't know if I have a picture of it. No. So at the beginning of each EKG, there's this little like box. Okay, it's like this little column that you see, which provides, tells you what the amplitude is. The standard calibration is 10 millimeters is equal to a millivolt. Okay, so it helps you kind of measure how big the EKG is, or how forceful the change in electricity inside the heart is. So if you have someone who has like really tall QRS complexes, they probably have a little bit more cardiac muscle mass than someone who has little itty bitty ones. And there's a number of other disease processes that can be affected. You can determine by the size of the EKG QRS complex, but you need to know that the box at the very beginning tells you what your calibration is. That's important also because you can change the calibration and like quote unquote zoom in by changing the calibration. So if you're like, let's amplify this, I've got really tiny QRSs, I can't really see the P wave, let me, amplify it, I'm going to make it a ×2, right? I'm going to make everything bigger. Your calibration is going to change as well, okay? Just keep that in mind. So if someone hands you an EKG and it looks funky, check the calibration because they might have blown it up or made it smaller. Any questions? Everybody still alive? Somewhat. All right, cool. It's a lot of info, and the good news is it's going to be recorded, so you can rewatch it, which I would recommend potentially rewatching some of this or finding other videos. I'll see if I can post some videos. There are some YouTube videos on EKG interpretation on the classroom, as well as a few games for EKG interpretation. So like you can pretty much play a game that like it'll show you a rhythm and you have to guess what the correct rhythm is. Very helpful as you start to kind of learn the basics. So we talked about this a little bit already, but there's different intervals and complexes that you will see within the EKG. And they all mean different things. But you do also need to make sure that you understand, just because you have an electrical impulse or electrical impulse tracing on an EKG does not mean that you also have mechanical conduction, right? This is why when you check for a pulse, it's important to know if it's there or not, because you can have somebody who has a beautiful EKG tracing and no pulse. You still have to do CPR, even though it looks like their heart should be working. So, it records it as the electricity as it moves through each part of the heart. So you start with your P wave, right? That's the green part right here, right? So if you start right here where the black turns into green, this is your SA node, okay? The SA node is firing. It's depolarizing the atria as it moves up and through the green. And then it gets to here where it turns back to black, and that's at the AV node, okay? You have a small pause, which is the end of the PR interval, okay? The R wave is the first upward deflection, okay? A Q wave, a small Q wave is normal, okay? But not everyone has a Q wave, so that's why it's called the PR interval, because you're looking for that first upward deflection. The S wave is the first negative deflection. So yes, we say it's a QRS. However, if you have a negative deflection, it will be an SR. Okay, so the letters can be moved around, but we could commonly call it standard QRS. Okay. So this is the electricity moving through the ventricles, up the Purkinje fibers, and then you have this pause right here. The pause between the S wave and the T wave is called the ST segment. This might sound somewhat familiar. It's commonly used as the first part of a STEMI. Okay, this is what we're talking about when we talk about STEMIs. It is an ST elevation myocardial infarction. That's what a STEMI is. That's what those letters mean. That means that when you look at the EKG, this part right here is not on the isoelectric line. It is up and it is not where it's supposed to be. Okay, it's elevated from the isoelectric line. You also might have T wave changes, and that's often due to the fact that when you have an occlusion, it changes the way the electricity moves, right? Because those muscles, the conduction system can be damaged as the myocardium is ischemic, okay? So we're going to talk about that more in 12 leads, but I just wanted to plant that seed so you can think about it, and we'll learn about it a little bit more in depth in the future. All right, so you move through this ST segment, and then you have the ventricular repolarization, right? So that's here, this T wave, and then you start back all over again, the isoelectric line, coming back around, waiting for the SA node to do something again. Everything starts on and ends on the isoelectric line. That's like your home base, okay? So if there's This is what you're using as a reference point for your ST elevations and other things as well. This is when your electrical potential is at resting, okay? So we talked about this a little bit now, but here's some of the specifics that you will 100% need to know, okay? The normal time, right? So we're going across because your time is on the horizontal axis. Your normal time for a P wave is 0.1 seconds or less. So we talked about what EKG paper timing is. EKG paper is 0.04 per little box. So that gives you about 3. So your P wave should not be more than 3 little boxes. Okay? In addition, the P wave should be about 0.5 to 0.25 millimeters high. Okay? So that's less than 1 box, right? It's a cute little tiny thing. Atrias are not particularly muscular, okay? So they don't really generate a lot of electricity. When you're interpreting EKGs, one of the first things you look at is to say, hey, do I have a P wave? Okay? If you have a P wave, that means that the electricity is coming generally, this general good rule of thumb, the electricity is coming from the SA node, okay? So if you have a P wave, it should be followed by a QRS, okay? It's totally possible to have a P wave and no QRS. The most important part of the EKG, when it comes to mechanical conduction though, is a QRS. You cannot have a pulse without a QRS complex. Okay? The atrias might try, but they are not muscular enough to pump enough blood around the body. Okay? So we always teach you, okay, do I have P waves? Yes. Do I have QRSs? Yes. Is it 1 for 1? Yes. When you're broadly looking at an EKG, you want to make sure that you have these big old QRS complexes, because if you don't, it's a strong possibility that your patient also doesn't have a pulse. Keep that in mind. So PR interval we talked about already a little bit, right? So this is the time it takes the electricity to go from the SA node to the AV node down here. It should be back down at the isoelectric line. And this is 0.12 to 0.2 seconds, okay? So 0.2 seconds is 5 little boxes, which is 1 big box. That's important to know. So if you have a P wave that extends a PR interval, right? So the P wave is over here, maybe, and the QRS is over here, and this is your big box. That's an electrical a heart block, okay? And we're going to talk about that more in depth in a bit, but keep that in mind, okay? So these are important times to know when it comes to interpreting your EKG. So your PR interval should not be longer than 1 large box. Now, your QRS complex, okay? We talked about how it is the representation of the depolarization of the ventricles. Super important. We like to ensure that those things exist, because otherwise you're probably doing CPR. Those QRS complexes, we like to make sure that they're cute and they're tight and they're sexy, okay? They should be very brief, okay? The electricity should be moving very rapidly down the normal electrical conduction pathways. So they should be 0.08 to 0.1 seconds in width, right? So from the beginning of when the electricity leaves the AV node to when it hits the end of the Purkinje fibers, this distance should be no more than 3 little boxes, okay? And now when you look at it up and down, you're expecting it to be 5 to 15 millimeters high, right? If it's anything taller than 15 millimeters, it's often considered in like that hypertension range, right? Or cardiomyopathy, right? That's a lot of complex. Usually it means that there's a lot of electrical of heart muscle associated with it, which may be a normal variant based on, like, if you're dealing with an elite athlete or, someone who has a known history of a cardiomyopathy or something like that, could be totally normal. So we talked about this already a little bit, right? So as the QRS is a kind of more intricate, complex than the P wave because of the way that the electricity does travel in the heart, okay? It mirrors the fact that it goes down the septum and up the left and right sides of the heart. So like if you flip this over, it looks pretty much exactly like it is here, right? It's just like kind of V shape. So just kind of keep that in mind that it really should kind of look like that, but depending on what angle you're viewing it is the way that the electricity is moving past your view, it could look a little different, but we'll talk about the normal EKG in a little bit. We spoke about this a little bit as well, right? So if the Q is the first little negative deflection and the R is the first positive, it might be a little bit different, and there's different ways that you may label it. So if it's going down like that significantly, it's a Q. This actually should be an R, so this should be a QR. If it's a little tiny wave, usually you use a lowercase letter to indicate that it's smaller. Not things that you're going to be really using, but just something interesting to know. Back to the complex parts of the EKG. So the ST segment, we talked about this already, right? This is what we're really viewing for acute disease processes, right? It immediately follows the QRS. What you're looking for is what's called the J point. The J point is this like kind of transition zone, right? So it goes from where the electric is moving to where it's hitting the isoelectric line. That's in a normal EKG. The J point can move anywhere up and down depending on what's going on in the ST segment, okay? So it's that kind of transition zone where you see it kind of starting to turn. So like if I was to say that this was, if this, for example, was where the J point is, see where it starts to turn? I'd call here the J point. And we'll talk about that a little bit more. You'll start to see it a little bit when you start working with EKGs as where the J point is. The ST segment ends when the T wave begins. Sometimes, again, this might be difficult depending on what kind of morphology changes are going on due to heart attacks or something to that effect. Here we go. So basically the PR segment, right, the isoelectric line kind of gives you the idea of where the J point should be. So if you look at here at example B, right, your J point should be here on this isoelectric line, but it's elevated all the way up here. See how it's moving from the QRS complex and then into the T wave, and that transition zone where it kind of changes direction, that's your J point. Or like right here, it's transitioning into the T wave, that's your J point. Certain issues like hypothermia can give you like a little funky J wave in here. So you can have a J wave and the J point is still that transition area. So a lot of different things that you can kind of pick up from an EKG. It's really interesting, and as you start to practice with it more, you'll kind of understand a lot more of this better. So keep an open mind. The T wave over here in this blue, okay, it should be in the same direction as the QRS, okay? So see how this QRS is primarily a negative deflection? The T wave should also be a positive deflection. This should also be a positive deflection. If this QRS was a negative deflection, it should also be a negative deflection, okay? They work in tandem because this is positive going to positive, this is negative going to negative, okay? And if it was negative going to positive, which would make a negative deflection, it would kind of mirror itself here. We talked about the different, let's see if it's right here. No. We talked about the absolute refractory, which is from the J point to the top of the T wave. And then the relative refractory, which is from the T point back to the isoelectric line. So T waves can do a lot of different things. We kind of become a little obsessed with them especially when you're like brand new, and after a while you're like, I'm not as impressed. But they tell you a lot of information, right? So if they come back to the isoelectric line and they kind of do this their normal thing, which T waves should be asymmetrical. Okay, they should go up pretty rapidly and then kind of curve down. Okay, that's a normal T wave. So if it doesn't do any of those things, if it's, for example, if it's very symmetrical and it's very pointy, it's indicative of hyperkalemia. If the T wave is kind of up in like dome shape, it might be a repolarization variant, or it could be moving into ischemia. Okay. If you do have, a T wave that moves in the opposite direction of the QRS, we call it an inverted T wave, and it's usually indicative of like a ischemia, but like more on the end of it being angina. Okay, like it could potentially be resolved, or it could turn into a STEMI if it's left alone and not treated. There's some strain patterns and stuff that you might see with patients who have high blood pressure. They might have T waves that do something kind of funny looking like that. A prolonged QT interval. This is dangerous for if you're going to be giving a patient Zofran. Okay, because it can create that R on T phenomenon, right, by extending the refractory period. Or all of these things are just, we're starting off, you're going to start to kind of become more familiar with them as you work with different EKGs. We can measure the QT interval, which is the beginning of the QRS complex to the end of the T wave, to kind of just to figure out how long it's taking for heartbeats and stuff. Not something that you really deal with all too much, but you should know, you should be familiar with it because it does indicate your refractory periods, which we did talk about. When you're looking at an EKG, one of the ways that you can kind of determine what the rate is to measure between the R waves, right? It also helps you determine if the heart rate is regular. So if you have different R to R intervals, okay, you might have a patient who has a dysrhythmia, okay? Might be AFib, might be a heart block, but this should be a relatively consistent time. Sometimes, healthy patients, if they take a deep breath, it might change the R to R interval, but it would be like an isolated issue, not an ongoing concern. Any questions? You all still with me? Okay, kind of. We'll talk, trust me, we'll talk more about EKGs. It's becomes like kind of it's a big topic, it's a lot to cover, but you're going to be so familiar with them after you start working with them more, you'll be okay. So one of the first questions you want to ask when you're looking at an EKG is the patient sick or not, right? Are you just doing your standard EKG because it's part of your patient workup, or are you doing it because the patient's complaining of chest pain, or the patient's complaining of shortness of breath, right? Is there something that you're specifically looking for, or is it just, I'm just doing my due diligence and looking, doing a quick EKG. My protocol says that if I give albuterol, I have to do, EKG monitoring, stuff like that. After that, what's the heart rate? Okay, you can do something simple and easy. Is it fast, medium, or slow, right? Do the QRS complexes look normal? Are the P waves looking normal? And is there a relationship between the P waves and the QRS complexes? So there's a number of different ways that you can analyze the heart rate. One of them is the triplicate method, which is really much more accurate when it's like a faster heart rate, or at least greater than 50. So basically what you do is you find a QRS complex that falls on the line of a big box, and then you count how many big boxes are between that QRS complex and the next QRS complex. And it'll give you like a average, like a kind of a ballpark range of what the heart rate is. So if you have a QRS on one big box and a QRS on the next big box, your patient's heart rate's 130. Okay, so if you have two big boxes in between, it's 150. Three big boxes, it's 100. 4 big boxes is 75. 5 big boxes is 60. 6 big boxes is 50. Okay, so it's a quick and easy way to kind of understand what you're working with. A lot of the times, when you print out, the monitor will also tell you what the heart rate is. You should also be taking a pulse, regardless of whether or not you're doing an EKG, because if it doesn't match, there's also another issue that you need to be looking into. Another way that you can do this is by measuring the R to R method, right? So we talked about if you're checking the regularity, you find out where one QRS is, where the next QRS is. You can then, then you count how many small boxes there are and divide by 1,500, which I don't think anybody's going to be doing that. And then, or you can count the large squares and divide by 300, or you could just use the triplicate method, which hurts everybody's head a little bit less, or, count. There's also the 6-second count method, which is not super accurate, but you get a 6-second strip. You count how many QRS complexes are in that 6-second strip, and then you multiply by 10. Again, not super accurate, but if you're doing some down and dirty paramedicine, then it might be helpful. Another way you can, the next step is to make sure that the rhythm is regular, right? Regular or irregular. We're going to determine what's going on, right? So there should be less than 4 small boxes of variation, right? And it could be contributed to respiratory rate or something to that effect. Back old school, they used calipers to measure. You can also take another piece of EKG paper, put it over the QRSs, draw little lines and move it down to see if it's regular or not. If it is a regular rhythm, you can also take your EKG paper, fold it in half, hold it up to a light, line up your QRSs and see if it's regular. There's a lot of different ways that you can kind of determine if the rhythm is regular or not. But it's important to know, because if it's not regular, it's moving you into a different classification of rhythm than if it is a regular rhythm. So as we said, right, if it's regular, it's one thing. If it's regularly irregular, it could be something like a normal, like a different heart blocks. If it's occasionally irregular, you might have a regular rhythm with maybe a PAC or something. If it's irregularly irregular, it's AFib. Okay, AFib is your only irregularly irregular rhythm. Well, sorry, the only perfusing or potentially perfusing irregularly irregular rhythm. The only other one would be VFib. What was that, Danny? Okay, just want to make sure you didn't have a question. All right. So, no question? No? Okay. So since step 3 is you want to look at your QRS complexes, right? Are they normal looking, right? They should be narrow or tight and sexy. A little too narrow could be an EKG or electrolyte imbalance. It could be that the heart rate is too fast, right? It could be an SVT that's going on that's causing it to be too narrow. Or it could be that you have this wide, funky QRS, which is either PVCs or a ventricularly conducted rhythm or a bundle branch block. Okay, there's a number of different things that a wide QRS can tell you. If you have somebody who has a wide QRS is sitting there like there's no problem in the world, it could be this normal variant for them, status post a pacemaker placement, or status posted heart attack where they have a bundle branch block now, or they just might have never known that they had something and it's just totally normal for them. So again, this is why it's important to look at your patient first, be like, are you sick? Are you okay? Analyzing the P wave then gives you a lot of information as well. So in lead 2, you should have a positive little bump of a P wave. They should be occurring at a regular interval, right? There should be a P wave before every QRS. There should be a close relationship between the P wave and the QRS. There should be very little variation between the amount of distance between each P wave and the QRS. And they should all look alike, okay? So If you have P waves with different morphologies, right? So like imagine this was your one EKG and you have 4 different looking P waves, that's going to tell you something different than if you have all these cute little P waves lined up looking exactly the same. Different morphologies also tell you different things. So if you have this like kind of stepped looking P wave, it's usually indicative of right atrial enlargement, right? So if the right atria is really muscular, it's going to give you a larger electric read than the left. Same goes for the left atrial enlargement. You get this cute little camel bump, all right, because then you can see the difference between the left and the right atria is being depolarized. And the same if you have both right and left atrial enlargement. You can also often see this in patients with chronic hypertension who don't take their medications compliantly. Just different variations, things to be aware of when you're looking. And again, as you practice, you'll learn more. Then you want to analyze your PR interval, right? So we talked about that a little bit already. So what's your relationship between the P wave and the QRS? They should be kind of closely married, okay? They're dating. Think of it that way, right? They're close enough to hold hands, but they're not like on top of each other where they're like a little too about each other, and they're not like over here where they're getting a divorce, right? They're happy, they're holding hands and just going down the merry way. If you have a very, very short PR interval, right, where they're kind of on top of each other, it's usually indicative of an accessory pathway like Wolff-Parkinson-White, and that can be a potential issue in the future with that patient if they're experiencing a tachycardia or chest pain or something like that. It's going to change the way that you treat them. Thoughts, questions, concerns? Okay, let's do this. All right, so different heart rhythms, different electrical rhythms come from different parts of the heart. The main pacemaker of the heart is your SA node, right? So you have 5 different rhythms that can originate from the SA node, starting with a sinus rhythm, followed up by a sinus brady, sinus tach, a dysrhythmia, or a sinus arrest. So your sinus rhythm, it will be anywhere between 60 and 100 beats a minute. It is always regular. The QRS complex is usually about 0.12 seconds. It's provided that there's no other conduction abnormality like a bundle branch block. Your P waves are going to be normal, upright. They're going to be, dating those QRS complexes. Your PR interval is going to be normal, okay? Given that, there's no other AV block present, which we're going to talk about how you can name rhythms based on blocks that might exist, but you still always need to know what the underlying rhythm is. So if you look at this EKG on the bottom, this is a perfect example of a sinus rhythm, right? Your P waves, each P wave has a QRS. They're within the proposed time frame. They're upright, they're tight, it's regular, right? So if you look here, right, it's pretty close to that main large box, right? So 1, 2, 3, 4. There's about 4 boxes in between each of them. So that's 300, 150, 175, give or take, right? So you're about a 70 to 80 beats per minute in this sinus rhythm here. Sinus bradycardia fits all of the same criteria from sinus rhythm, except the rate is less than 60. Okay. Yes, that means if it's a heart rate of 58, it's still considered sinus bradycardia. Okay. So if you look here, this is a 6-second strip. Let's do that method, right? You have 4 QRS complexes. This is a heart rate of approximately 40. Okay. This could be totally normal for some people. This could be detrimental to life for others. Sinus bradycardia, again, we said it could be completely normal or it could be caused by some sort of intrinsic disease. Increased parasympathetic tone, right? Those little old people who go and have a bowel movement and then brady themselves down, that's your increased parasympathetic tone. Hypothermia will slow heart rate down because of decreased metabolic necessity. Hypothyroidism, because it screws with your metabolism, will also slow the heart rate down. Various drug effects, right? Beta blocker overdoses, calcium channel overdoses, stuff like that can cause a slower heartbeat. If you do need to treat it, right? If you have somebody who has evidence of compromised cardiac output, right? So hypotensive, dizzy, chest pain, AMS, right? And they also have sinus bradycardia. There's a number of things that you can do, right? So you can look at your protocols, which I highly recommend you start looking at your cardiac protocols before you get to your skills labs coming up. But you can be using atropine is your first line drug for sinus bradycardia, followed up by your pressors, right? Dopamine, norepi, or epinephrine. And then if you have a seriously critical patient, transcutaneous pacing, right? You slap those electrodes on their chest and you pace them, which is funny to watch, but probably terrible to deal with because I'm pretty sure it's extremely painful. I've paced one person and he owed the entire way to the hospital. So things you should also kind of keep in mind is when you turn the pacer on, it immediately starts pacing them. Okay, you don't really notice that when you're doing it on a mannequin, but in real life, when you turn the pacing machine on, it immediately starts to pace. So if you're going to be a nice person and give them some sedation, do it before you start pacing. So sinus tachycardia, when you look back at our criteria for the sinus rhythm, you have a P wave. It's married to the QRS wave. The QRS wave is cute and tight and sexy, but this is a heart rate of over 100. Okay. Generally, a sinus tachycardia is between 100 and 150. When you are over 150 beats a minute, you start to move into the supraventricular tachycardia realm, and we'll talk about that coming up really shortly. Okay, so if you look here, right, you can do your 300, 150, a little bit over 150 beats a minute over here in this sinus tachycardia. Again, did your patient just run up a flight of stairs and now their heart rate's here where that's normal, or is there something else going on? Patients who have a fever, right, infection or any sort of level of sepsis or caffeine intake, hyperthyroidism, can all be experiencing tachycardia. For the most part, a lot of tachycardias do really well if you let the patient relax, maybe give them some fluids if they're dehydrated. Oxygen's helpful. If you have a patient who, just amputated their leg and they're in pain and that's why they're tachycardic, you could be nice and give them a little fentanyl. That'll help their tachycardia as well. We talk about sinus dysrhythmias. They can be completely normal variations, especially in younger patients because of intrathoracic pressure caused by the respiratory cycle. Can be totally normal. If it's like really, really funky, then it might be something else, but generally we aren't treating sinus dysrhythmias. They're usually between 60 and 100 beats a minute. The rhythm won't be as regular as you see with a sinus rhythm, right? But you'll have maybe a prolonged period here. It could be caused too if the patient's bearing down, right? Like that parasympathetic tone increase, or just due to the respiratory cycle increasing vagal tone. Sometimes if adults have heart disease and are on certain medications, you can see this as well. As I said, most of the time this is not like clinically significant where you're going to be really treating it in an active manner. Sinus arrests are fun though. I know Soraya had a sinus arrest with a guy a few weeks ago. He stopped having a pulse for about 10 seconds and went unconscious. So basically it's your heart's ticking along a-okay, no problem, and then all of a sudden the SA node doesn't fire and nobody steps up to fix it either. Okay, so you get this like long asystole version here. Depending on patient status, like how healthy they are, as well as if it comes back or not, they can lose consciousness. They might just be like, it feels really weird, right? They might just have some odd chest pain. They might even say that it feels like a flutter. And depending, you might have some escape, we call them junctional escape beats, right? Those are PJCs. So you would have this tight QRS complex but no P wave. That's the heart trying to like make sure that the body stays alive. Most of the time it's caused by some level of probably usually a electrolyte imbalance that causes the SA node to not be able to generate as much electric as it usually does. You can fix those things with atropine or transcutaneous pacing, especially if it's ongoing like that. Then that sinus arrest is a long, prolonged period, especially if there's no escape beats, right? If there's no PJCs or PVCs trying to kind of pick up the slack where the heart rate is concerned. Again, not something you see a lot, but when you do, you kind of go, oh my, let me do something about it. So this is what you could do. Moving on to the atrias, right? So if the SA node decides it's grumpy, doesn't want to do anything, you have all of this electrical conduction system within the atrias that would usually pick up the slack. It could also be any singular cell of the atrias that decides to take over as the new primary pacemaker, okay? It's kind of cool that your heart has these like different backup systems built in. So, wandering atrial pacemaker, again, we're over the AV node, so it's going to be a rate between 60 to 100. Usually the SA node is still doing kind of what it does, or there's some atrial cell that is doing what it should do. But what happens is you get what we call the wander, okay? So you'll see here, okay, that P wave looks like that P wave, which kind of looks like that P wave, which looks that looks a little different, and like, oh, that P wave is totally different, and oh, this P wave is different, right? So you have different cells that are kind of creating the overall pacemaker for the heart, okay? Sometimes it's hard to tell, because the P wave might be buried in the QRS, or they might look very, very similar because perhaps they're like right next to each other. But a wandering atrial pacemaker is kind of one of those interesting finds. Usually, again, it could be caused by heart disease. It could be like a precursor to AFib. Vagal stimulation, right, where they're kind of knocking the SA node out of commission, could be causing it, as is digoxin does that as well. If there's no serious signs and symptoms, you're monitoring and going to the hospital. If there's some sort of underlying cause that you could identify, then you can treat. PACs, okay, are like an addition, okay? You can't just say, oh, the patient has PACs. No, the patient needs to have an underlying rhythm and PACs. So for example, if you look here, you've got, it looks like a sinus rhythm, right? You've got a P wave and a tight QRS, P wave, tight QRS. And then you have this extra rhythm, the extra P wave and a different QRS, okay? So this would be, I would call this a sinus rhythm with PACs, okay? It needs to have, another term to it. Or it would be a sinus bradycardia with PACs, okay? PACs do not stand alone. You need to have, an associated rhythm with them. The P wave is usually a completely different shape than the underlying rhythm's P wave, okay? Because this does go down the normal pathway for the ventricles, like the AV node, the QRS complex is very commonly will be the same size and the same shape as the normal rhythm. Sometimes this patient, this is like a bigeminy PAC situation in this guy. But depending on the frequency of the PACs, yes, it could look like it's AFib. So for younger patients, younger healthy patients, PACs are completely like whatever, no one gives a crap. Usually it's caused by caffeine, alcohol use, relative levels of hypoxia can cause it for like older patients who are not in good shape. But the more frequently PACs or any premature complex happens, the more likely you'll go into a dysrhythmia. So usually they'll just monitor them, but that's not a lot that we do if we have an isolated finding of PACs. Now, SVTs are going to be some of like the most fun jobs that you have. You'll have a patient who's like, I feel like my heart is racing. And you're like, okay, sure, whatever. And then you go take a pulse and it's like, you're like, oh, who put a hummingbird over here? It's a rate of 150 or higher. I know that it kind of caps it at 250, but the younger the patient, the more the heart can sustain. So like young children, like under the age of 10 or so, can maintain a heart rate in the 300s for a lot longer than any other human being can. Sometimes you might not be able to see the P waves because the rate is so fast that it gets kind of, what's the word? Yeah, buried. Thank you. Kind of gets buried in either the T wave or the QRS complexes. So you're going to use, this is one of those times where you might use your axis to find out if the EKG is a SVT or if it's VTAC, okay? If you look here, if you do the count, right, you have 300 and, 150 would be here, so this is over here, probably in the 170s, this heart rate. SVT is just, it can be very commonly found in young adults. If a patient has had an SVT episode before, they will tell you. They're going to be like, I needed 12 of adenosine last time. And you're going to be like, oh, really? Did you now, right? They'll already be trying vagal maneuvers. If you really have to, you might have to use synchronized cardioversion. Again, this is one of those things where it would be really nice if you sedated them. It cannot be sustained for an extended period of time because it does increase the oxygen demand of the heart. So if you have a patient who's in SVT for an extended period of time, they might have ischemic changes caused by that really rapid heart rate. Usually you don't see this dysrhythmia with a heart attack, okay, with an MI or cardiovascular disease. This is more commonly seen in younger people, or if you have a patient who takes medication for AFib, for rate control, you might see them in a rapid AFib with ventricular response, which technically falls under the larger umbrella of a supraventricular tachycardia, okay? But as I said, commonly it's younger, healthier adults. Often I like to also say, make sure that like your patient's not compensating for something, especially if they're older, right? So if they have like a really high heart rate in like the 160s, but they're also like in shock, you don't want to like cardiovert that and take away their compensatory mechanisms. You maybe want to give that patient fluids and see what happens to their heart rate first, okay? This is where we start to kind of use those critical thinking skills to make sure that we don't cause harm to a patient. Here's our different classifications of SVTs, right? So AV node reentry tachycardia and AV reentry tachycardia on the bottom are usually like your Wolff-Parkinson White, okay? So there's a pathway, an accessory pathway that's causing the atrias to fire faster. Atrial tachycardia is just, there's a unspecified cell in the atrias that's firing off, and PSVT is paroxysmal supraventricular tachycardia. That's when you can see it start and end, okay? If you do not see the SVT start and or stop, it's just an SVT, okay? It's only paroxysmal if you see it initiate and or terminate, or both. So a flutter is in very unique rhythm that you're going to see, and it's got what we call sawtooth. It doesn't have P waves. These are actually considered F waves, F for flutter, okay? And we call it sawtoothing, okay? It's a very unique pattern that it will create. Very commonly, you will have a ratio between the flutter waves and the QRS complexes, which is usually constant. A flutter is very commonly seen in conjunction with AFib. A flutter can also deteriorate into AFib. Okay, it may or may not be this fast. I've seen a slow A flutter at a rate of 40. Okay, doesn't mean that, most of the time you'll see over here with the more frequent ratios, okay, where it's like you got what, 1, 2, 3, it's a 3 to 1, maybe even a 4 to 1, because the T wave is getting lost in the flutter waves, okay. For the most part, A flutter is a constant rhythm, okay, it's not irregular, but you do have these funky looking flutter waves. Usually older patients do have this. Most of the time it's coronary artery disease. As I said, it will deteriorate eventually into AFib. If you have a patient who does have a 1-to-1 conduction ratio, that can get very, very fast in the heart rate, and they will deteriorate very quickly. But these are some of your options with how you can treat it. Cardizem is the calcium channel blocker, right? So that it will help reduce this speed of the conduction as well as the muscular contraction. So it's going to slow down the rate and how quickly it's transmitted. So AFib. AFib is your only irregular rhythm that you're going to deal with that is conducting, because ventricular fibrillation is also irregular, but does not conduct mechanical pulse. You do not have P waves. You also do not have a clear and definitive isoelectric line. You have what we call a fibrillatory line, okay? Because it's doing that funky Harlem shake here on the bottom, okay? So the rate is completely dependent on how well the AV node is functioning, okay? If the AV node is, not being overstimulated by all the fibrillatory waves coming through, you can actually have a relatively regular looking AFib, okay? If patients are being medicated with rate control medications, you also might have a relatively regular looking AFib. But then again, you could have somebody who's going from a rate of 20 to a rate of 120 and bouncing all over the place. This is why it's important to take a pulse for 60 seconds for this kind of patient. Usually AFib is generated by a number of different overactive atrial cells, and those cells most of the time are around the aortic valve. So if you have a patient who has aortic valve stenosis, they might also have AFib, okay? Hypertension does similar issues, right, because of the pressure it's putting on the aortic valve, as does obesity and sleep apnea. Again, same kind of rate control treatments that we're going to use for a flutter. Endurance athletes are at a risk because they just put a lot of strain on the aortic valve. Ingestion of alcohol for younger patients could cause like a little momentary AFib. Most of the time you're going to see the older patients who are chronically maintained with medication who have forgotten to take a medication is usually the group of people you'll probably be dealing with. All right, so we've moved down to the heart. The SA node has quit on us. The atrias have quit on us. Now we're here at the AV junction, okay? They often will use like a junctional rhythm, quote unquote, the junctional rhythm to define things that come from the AV node. The AV junction is just another term for it. It sounds a little sexier. Let's just call it a junctional or escape rhythm. So just keep that in mind. Premature junctional complexes, again, this requires an underlying rhythm. So if you have a sinus rhythm with PJCs, that is correct. You cannot just have PJCs, okay? Because if you just have PJCs, you have a junctional rhythm, okay? It's not sinus. So if you'll see here, right, you have your sinus rhythm. It's got a P wave, P wave, P wave, P wave. And then over here, you have this one complex that didn't bring its P wave to the party, okay? That's your junctional rhythm, or your junctional complex. The junctional complex can also have an inverted P wave that's caused by the electricity going the opposite direction from the junction to the atrius, okay? Just keep that in mind. As long as there's no underlying ventricular conduction, it's going down the normal electrical pathway, so it's going to be that kind of sexy QRS complex where it's tight. The rhythm will be depends on the underlying rhythm, right? So sinus rhythm, sinus brady, etc. But the PJC can cause what's called a compensatory pause. Okay, see how that distance there exists? That's because it's potentially just the heart needs to reset, right? You have that refractory phase that the heart needs to go through before it can generate another normal complex. Usually it could be it's not a clinically significant issue. Younger patients deal with PJCs all the time with, never really noticing that it's a thing. Vagal tone, like an increased level of vagal tone on the SA node, can cause the junction to kind of step up and try to create a rhythm. But once that SA node is back at it, it gets overridden again. Again, hypoxia is usually the number one cause of any sort of premature complex. Okay, that's a test question. Hypoxia is often the cause of premature complexes of any kind. Okay, atrial, junctional, or ventricular. So, if the SA node and the atria have completely abandoned ship, the junction will take over, and this is often called a junctional escape rhythm. An escape rhythm in so much as we are escaping death. This rate is intrinsic at 40 to 60 beats a minute. There will be no P waves, or if they are, they will be potentially inverted or after the QRS, okay? You might not even see them. If they're buried inside the QRS, it might make that QRS look a little funky, okay? But if it's, inverted or after the fact, it won't really affect what the QRS looks like. For the most part, this is caused by significant issues in the SA node, an inferior wall MI, rheumatic fever. Any of these things can cause some issues, okay? If the rate is appropriate, like if this is an escape rhythm at on the 60 end, it's usually well tolerated, okay? But if you have a patient who's at the 40 end and they're not generating enough cardiac output, because remember, you're still losing some of that atrial kick, they might need to be treated with atropine or your transcutaneous pacing. And again, a lot of this, you can't treat the monitor, you have to treat the patient. So just because you have a patient who has a junctional escape rhythm on the monitor doesn't necessarily mean that you're going to be doing anything for them right away. So back to their situation where our SA node and atrias have quit on us, sometimes the junction can really step it up and it will give you a rate of 60 to 100. This is considered an accelerated junctional rhythm, okay? An accelerated junctional rhythm is at like a normal rate of 60 to 100, what was considered like a normal heart rate. You can also have a junctional tachycardia, which is no P waves at a rate of over 100. Okay, so think of these phrases as kind of generically used between everything, but you need to identify where the origin of the electric is coming from. So again, you might have inverted P waves or no P waves at all. You'll probably have those really cute, sexy QRS complexes, but you'll be at a rate of 60 to 100. Sometimes this is hard to pick out, okay? A lot of people can miss an accelerated junctional rhythm because you're like, oh, it kind of looks like a P wave. Yeah, that's probably a P wave. So just be really careful when you're looking. Again, at these rates, often you don't need to do anything for an accelerated junctional rhythm. The patient won't even necessarily know that they're sick. It's usually an incidental finding, but something good to know when they get to the hospital because they might need a cardiac follow-up or cardiology follow-up. Bleh. Okay. Questions, thoughts, concerns? Okie dokie. Moving on to the ventricles. So now everyone has quit on us. The SA node, the atrias, the AV node is even given up, okay? The ventricles can generate a rhythm anywhere from past the AV node down to the Purkinje fibers, okay? Generally, the rate is between 20 and 40. That's the intrinsic rate, okay? A ventricular escape rhythm is also called an idioventricular rhythm, okay? Depending on how slow it is, like if you start to drop below 20, that's when we start to call it an agonal rhythm, right? The heart's, it's quitting. It's not going to do anything particularly useful for life. It's an agonal rhythm, sort of like agonal respirations. For the most part, the rhythm is relatively regular here in our idioventricular land. The QRS complexes, however, will be kind of wide and kind of bizarre, okay? Because remember, it's not necessarily going down the normal electrical conduction pathway, so you lose that tight sexiness that it had when it was coming from higher up. May or may not have P waves, but if there are P waves, the PR interval might not be regular. This is usually one of the first rhythms that you see after you defibrillate a patient, right? It's like the heart's trying to like restart itself. It's like listening to an engine kind of trying, it's trying to build up some speed. Usually if you have a patient who has their heart starting to fail from the top down, you'll see them as being hypotensive, bradycardic, without putting them on the monitor, right? They might be significantly AMS, right? They may have passed out have a syncopal episode. Everything that you're really going to focus on is on increasing the heart rate, okay? Because this patient's most likely, like 99.9%, going to need a pacemaker. That other 0.1% is they got rid of the toxins that were causing the issue, or they die. So your transcutaneous pacing might be something that you're going to jump to right away, right? You might do a trial run of dopamine if they're still kind of with it a little bit. But for the most part, you're going to probably need to be extremely aggressive in this kind of rhythm. PVCs, again, we talked about this, when it's just a normal extra kind of complex, it just pops up out of nowhere, and usually in a healthy patient. It will be this wide, bizarre looking thing. What you always need to know is what's your underlying rhythm plus PVCs, right? So this would be a sinus rhythm with a PVC. Now, PVCs need to kind of also be identified in terms of if they are unifocal or multifocal, okay? So if you have a single, let me go back to this real quick. If you have a single kind of pissed off ventricular cell, it's going to create the same morphology over and over, okay? Commonly, those cells become pissed off because they're hypoxic. If you have more than one cell that's a little irritated, you're going to have different morphologies. So one might look like this, the other might be upwards or like wider. So that's how you determine if it's unifocal or multifocal. Okay. Again, commonly, hypoxia. MIs can cause irritation, right? Because now you're having hypoxia secondary to an occlusion. Acid-base imbalances can cause it. Hypokalemia. Stress, just regular old stress can cause it. If you have three or more PVCs right after each other, it's considered a run of VTAC. You need to take that seriously. If you have a patient who has more than 5 PVCs in a minute, again, this is something you need to take very seriously because they may go right into VTAC on you, okay? So they need careful monitoring and some oxygen therapy to make sure that they don't do, some funkiness on you and make you look bad when you drag it in somebody who's not doing as well as they were previously. So here's an example, right? So this is a multifocal, right? So you have one morphology of a PVC followed by a different morphology of a PVC. So that's two totally different cells that are kind of pissed off. Same thing here, right? Add one more PVC to this combination and it would be considered a run of VTAC. Here you have a unifocal PVC, right? That in very unique, repeated morphology of the PVCs, as is here, right? So the interesting thing here is this one down here is called bigeminy. Bigeminy is defined as a normal complex followed by a PVC, okay? And that in itself is its own rhythm. Okay, you don't need to say, oh, this is sinus rhythm with whatever. This is bigeminy. Okay, it stands alone. Over here, where you have two normal complexes followed by a PVC and then repeated, is called trigeminy. Okay, think of it by two, right? 1 and 2, tri, 3 complex pattern. Okay, things to keep notes on that you'll see in the future. So here, right here, you got 1, 2, 3, 4. That's a run of VTAC. Here's your multifocal PVCs. Here's bigeminy, and here's trigeminy again. Okay, just giving you a little different picture for clarification. So VTAC. VTAC is when your heart, so the ventricular cell has taken over and it's pissed off, okay? Usually it's a rate of 100 to 250. Usually, if you have it, usually I see a lot of the time at 120 or higher. It's usually a wide, bizarre, and very looping kind of morphology. It's essentially it's just a PVC combined to another PVC. However, another morphology of torsades is called of VTAC is torsade de poids, okay, or the French for turning at a point, okay? So you kind of see how it does this, like, it gets really big and then gets small and then turns again, okay? That's just the different cells of the heart taking over as it creates this tachycardia. It will be over 100 beats a minute. It's commonly associated with myocardial ischemia, acid-base issues. Sometimes sympathomimetic drugs can cause it, right? So I had a lady once who was saying that she was really stressed out at work and that she was drinking a lot more coffee than usual, and she was in runs of VTAC longer than me, okay? Like, that's a lot of VTAC. VTAC with a pulse can be sustained for a certain amount of time, but you do need to treat it, right? That is a fatal rhythm that needs to be corrected immediately. Oxygen obviously is your first bet. Synchronized cardioversion is your most aggressive manner. So like if you have a patient who's extremely hypotensive, they need to be cardioverted. If you have somebody who is hanging out at a really decent blood pressure but is still in VTAC, amiodarone, okay? If you have someone who is in torsade de poids, they require magnesium, okay? It's very commonly caused by low magnesium levels and that R on T phenomenon that it kind of flips them into a really interesting rhythm. Now VFib. Shocking. That's all you need to know. Just kidding. Nothing's coordinated, right? The heart has literally just given up. It's just freaking out. It's commonly caused to significant hypoxia secondary to ischemia or any other significant issue, cardiac issue. It could be caused due to aortic dissection, right? Overdose. If the heart starts to slow down significantly due to a high level AV block, a lot of different things needs to be defibrillated. Okay, VTAC can deteriorate into VFib. Okay, that's the common course of action. So you need to make sure that you deal with it and you deal with it quickly. Other things that you should just know right now, rhythms that you might see is an artificial pacemaker. So you get this little like spike right here. That little spike is the battery from the pacemaker charging the heart to make sure it works. May or may not be visible. Most of the time it is. You can have a runaway pacemaker, which is kind of fun. You treat that with a giant magnet. I wish I was joking. So basically, you'll either feel the pacemaker or you'll know, the patient will tell you that they have a pacemaker. It can be just the atria, it could be the atria and the ventricle, depending on what's being stimulated. Just because a pacemaker is going off doesn't necessarily mean that you have either electrical or mechanical capture. So you need to, check a pulse and put them on the monitor. Non-shockable arrest rhythms, right? This is the stuff that they always shock on TV doctor shows. So you have pulseless. Hold on. All right, we'll go with asystole because that's the easiest one. Asystole is flatline, right? You don't shock it. You don't get that back unless you do some significant treatment of your H's and T's. Most of the time, all of the electrical generated in the heart has ceased to exist, they're not likely to survive. There's like a 2 or 3% survival rate from asystole. Your H's and T's, right? We will probably talk about them more in depth, but these are the ones that you need to know. They're all the different causes of cardiac arrest. CPR and epi might improve, but you do definitely need to do CPR. Pulseless electrical activity is a very interesting idea. Okay, so you cannot have a rhythm called pulseless electrical activity. It is a state of being. It's like being Zen. Okay, you can have any cardiac rhythm that is a pulseless electrical activity, except for your obvious VTAC or VFib. Okay, so you can have a sinus rhythm that is pulseless electrical activity, or PEA. Okay, you need to identify the underlying rhythm in order for you to be taken seriously as a medical professional. It is not just PEA. Okay, you have to identify the rhythm associated with it, because then that can also bring you back to how you can fix it, right? Your H's and T's, what's caused it, what kind of medications might I consider, etc., etc. Hey, look, there's your H's and T's again. All right. You okay? Y'all survive? We're going to stop there because I think that's enough information for today. Good. All right. Any questions? They've both also fallen asleep. Their brains imploded. They're done.